And now we move to the thing that no one wants, complications. And the next person that will actually present will be Dr. David Ruch. He's a professor of orthopedic surgery and the chief of hand and microsurgery in Duke University, Durham, North Carolina. He was my teacher. He loves complications. And I'm sure he can enlighten us in this section. David?
Well, thank you, Nico, and thank you, Alex, for a great talk. I need to share my screen, and then I'll just get on presenter mode here, and away we go. How are we doing? Is that good, Nico?
Yes, this is fine.
All right, perfect. Okay, so I guess I'm presenting on complications, and I'd like to do it in sort of a case-based format to make it a little bit more interesting. These are my disclosures, and I would say that I'm willing to take money from anybody for a little bit of research support. So this is just going to be a case-based approach to operative management of a very common fracture. So we're going to look a little bit about percutaneous pinning, external fixation, dorsal plating, and palmar locked plating. As far as pinning goes, the results of pinning seem to be very patient dependent. At the end of 12 months in several prospective randomized trials, at least in our elderly patient population, they seem to adapt very well to some loss of motion. And if there is any collapse associated with this technique, it is exceedingly well tolerated in elderly patients. Younger patients are a little bit less tolerant, but seem to adapt well over a long-term study. But again, pinning seems to be very patient dependent. And I think it's also very fracture dependent. I think we would all look at this fracture and say it is exceedingly comminuted extending proximally. And the Kapanchi technique that was used in this situation did not really allow for sufficient metaphyseal stability. And you can see the loss of height and the dislocation of the distal radial ulnar joint with this particular technique, which was revised with a standard volar plate and an associated dorsal spanning plate. We look at external fixation. External fixation was originally introduced because we thought we could then neutralize that axial load associated with collapse. We felt that it didn't really restore palmar tilt, and so the adjunctive Kirschner wire fixation was employed. But the results really were tremendously good. In the article that Alex quoted by Hans Krieger et al., the use of external fixation was actually superior to internal fixation in a very nice prospective randomized trial. The problem that we really saw with external fixation was with that critical corner that was originally described by Jupiter et al., Neil Harness's paper in the JBJS. And really what happens is that you can see in this impaction type fracture, the surgeon's unable to get the fracture disimpacted with simple traction. And so then you see over distraction. And this is what we were seeing at the time, was these patients would come in with very poor digital motion. And we associated that with this technique of external fixation. And when we looked at it in the lab, what we actually found was that if you distracted the wrist in a cadaver over about 5 millimeters, that you would see statistically increased loss of digital excursion with external fixation. And that was particularly significant for the index and long digits, as you might imagine. The further over ulnarly away from the line of pull, you had improved digital motion. And so what that led to was you saw a patient like this, where the patient was overly distracted. and you test the digital excursion, you see that the finger springs back up into extension. And in that case, you can put in your adjunctive fixation and or bone graft, and then that allows you to take some of the distraction off. This is a useful test when you're doing a bridge plate as well. And I do this before I put in my proximal screws. I clamp the bridge plate and then test for digital range of motion and make sure that you don't see that springing back that you saw there with the digital extensors being too tight. When we look at dorsal plates were really initially described as a buttress type technique. And what we found with dorsal plates was similar to what we found with locked plating in the tibia and in the femur, was we saw collapse opposite the point of fixation with the plate. And so these distally placed screws have very poor pull-out strength. And what we saw was collapse of the fracture opposite the direction that we were placing the plate. And so you can see that the fracture collapses in a palmar direction. And when that happens, it's a particularly virulent type of collapse pattern. It's worse than cast treatment in a way, because we get collapse opposite the plate. The plate is then very prominent dorsally, and you see that the distal radius has collapsed palmarly, and that dislocates the DRUJ. And so this is the characteristic thing that we were seeing with these dorsal plates, was the DRUJ incongruity, because the radius is palmar and the ulna is dorsal. And then we're also seeing that the dorsal plate is prominent, and you would see EDC ruptures from this. And despite changing the metallurgy and the designs, it was really simply how they were collapsing. And one of our co-speakers today, Tassos, did a brilliant paper in which he looked at the angle that the screws were taking with the dorsal plate versus this angle that the screws took with the palmar plate. And what he saw was that there were obviously fewer extensor tendon ruptures based on the angle that the screws were subtending. And so you could see that a palmarly based plate is able to capture the dorsal margin of the radius from below, whereas a dorsally placed plate cannot capture the critical corner from the dorsal aspect based on the palmar tilt of the radius. And that enters the era that Dr. Orbay has so brilliantly popularized with palmar locked plating. And the advantages have already been espoused by Alex's talk, but you can see that we were getting immediately really good results with this technique. Unfortunately, we were seeing with increasing use of a particular operative technique, you're going to see an increase in the number of complications as well, just based on the numbers being performed. And so I'd like to just touch base on a couple of those. First is just malunion in general. Malunions following plating are probably less commonly appreciated because the hardware obscures the articular reduction. And that was particularly apparent in this woman. You can see that she presents with some degree of loss of extension, but you can see absent supination of the left wrist. And you look at the radiographs and it looks like she's got reasonable palmar tilt and articular reduction seems reasonable. And you might say that that would be acceptable. But when you take off the plate, then you see that in fact the hardware was obscuring the fact that the radius is significantly palmarly tilted, thereby again dislocating the distal radial ulnar joint and resulting in that loss of supination that you saw. And a simple extension type osteotomy with a graft restores the supination and extension in this patient. The other thing we really have been focusing on that Alex alluded to is the palmar lunate facet, or the so-called critical corner. And as we have been approaching these fractures from a palmar approach, we've gained a really great appreciation of the significance of these smaller volar rim fractures, as you can see in this particular patient. This is a surgeon who presents following a underappreciated fracture involving the rim of the radius, and you can see the apparent subluxation of the carpus relative to that as that occurs. And these can be very difficult fractures to manage. As you could see here, this would be difficult even with a variety of techniques, and certainly when they're appreciated late, as it was in this young man. This is a significant problem. And you can see here he is with, again, that characteristic loss of extension. And then you can see that characteristic loss of supination that goes with the failure to capture or correct that critical corner. And in this case, we reported on a group of these patients in which an osteotomy of the critical corner can be performed through a volar approach. And you can push the carpus back onto the margin dorsally, reducing that critical corner. And then there are a variety of different techniques for maintaining that, but I think they all require some degree of neutralization of the wrist. And so we use expanding locked plate to accompany this. This is an early case, and here you can see the use of a standard 3.5 DCP plate on the dorsum that neutralizes the tendency for the carpus to follow that critical corner, and then capturing the critical corner with a K-wire and then a very distally based plate. And then at union, the spanning plate can be removed, plus or minus removal of the volar locked plate. This is what it looked like when we were finished. You can see the carpus are now reduced, and the DRUJ is now reduced as well. This patient recently presented back with Dacquerbain's tenosynovitis, and I was able to re-X-ray him. You can see here the maintenance of the reduction at 8 years, and this is the range of motion in the same individual. Again, we have a variety of complications that are being reported with this technique, and soft tissue complications are perhaps more frequently involved now with these more invasive techniques. So when we look first at extensor tendon rupture, that has been linked to drill bit penetration dorsally, but most commonly it's going to be a prominent screw tip, and perhaps, and I've seen this in a variety of patients, by not visualizing those dorsal fragments, perhaps they are very prominent. And I've had several extensor tendon ruptures where I've expected them to be secondary to screw placement, and they have been secondary to simply a rough surface on the dorsum of the radius. This is one of my early cases. This is a nurse who really requested operative treatment because she was in the middle of her training. And this is early in my career, and I was very excited with this result, and I was very pleased with her very good early range of motion. And then I noticed that her thumb IP joint was not extending, and she had an obvious rupture of her extensor pollicis longus. And as Alex alluded to, when you look at your post-operative radiograph, you can be fooled by the appearance of Lister's tubercle. And again, you really do need to get a variety of views, which he has already described. But Interestingly, Nico's project as a fellow was actually looking at this and documenting 45-degree pronated and 45-degree supinated views show these prominent screw tips very nicely. So Nico, congratulations to you. But this is the appearance. Lister's tubercle is here, and the extensor pollicis longus is ruptured there by that prominent screw tip. Finally, we're seeing a lot more flexion tendon problems with this technique. The FPL is most commonly reported, but the FDP index and indeed even FDP ring and long have been reported as well. And it probably has to do with where the screw is being placed. Where the plate is being placed relative to the watershed that was previously pointed out by Phil Blazer and his group in Brigham. And what we saw with this is that the watershed really is very distal on the ulnar aspect of the radius volarly, but it is fairly proximal on the radial column. And you really have to remember this when you look at where your plate is being placed. And it's not really even apparent on the lateral radiograph. You have to take into account the lateral and the AP. You do want your plate to be distal on the intermediate column, so you capture that critical corner that we talked about, but it has to be proximal on the radial column to avoid prominence on your FPL or FDP index. And this is such a female MVC, high energy fracture. You can see here the surgeon recognized it, initially treated with an external fixator, felt like that was not sufficient, and applied a palmar locked plate in addition to that. And you can see here with that palmar locked plate, the hooks are fairly prominent. And the fracture is not well reduced, and the patient goes on to a FDP index rupture on that very prominent volar plate. And I've seen this occur both early and late. And I think it's primarily due to distal plate placement on the radial column. That seems to be the most important aspect of it. In this individual and in most individuals like her, particularly over about 55 to 60, I have not been doing a two-stage graft of the flexor. And this patient is quite pleased with her simple hardware removal. And she does have a flaccid index DIP joint, but tolerates it quite well. So in conclusion, I think complications following operative management of common fractures will occur, there's no question. But I think recognition of the significance of prominent hardware cannot be overemphasized, and recognition of the significance of the palmar lunate facet cannot be overemphasized. And as in many things, don't repeat the same mistake and learn from my mistakes. Don't make them yourself. So thank you very much. And this is a testimony to what Alex pointed out. We've all aged just a little bit during our time away from each other, but I look forward to visiting you in Greece very soon. And thank you for the invitation to speak today.
Thank you, David. Thank you for the photo. We did change a little.